Cholelithiasis Hong I Kui, MD, PhD Basics Description: the presence of cholesterol, pigment, or mixed stones, calculi, within the gallbladder. Synonym: gallstones. Pediatric considerations: uncommon in children. 10 years. Most gallstones in children are pigment stones associated with blood dyscrasias. Epidemiology: incidence increased in Native Americans and Hispanics, increases with age. 3% per year, peaks at 7th decade. 2% of the U.S. population develops gallstones annually. Prevalence: 8–10% of the U.S. population with gallstones. 20% greater than 65 years of age. Female, male. 2 to 3:1. Etiology and pathophysiology: gallstone formation is a complex process mediated by genetic, metabolic, immune, and environmental factors. Gallbladder sludge, a mixture of cholesterol crystals, calcium bilirubinate granules, and mucin gel matrix, serves as the nidus for gallstone formation. Bile supersaturated with cholesterol, cholesterol stones, precipitates as microcrystals that aggregate and expand. Stone formation is enhanced by biliary stasis or impaired gallbladder motility. Decrease in bile phospholipid, lecithin, or decreased bile salt secretion. Excess unconjugated bilirubin in patients with hemolytic diseases, passage of excess bile salt into the colon with subsequent absorption of excess unconjugated bilirubin in patients with inflammatory bowel disease, IBD, or after distal ileal resection, black or pigment stones. Hydrolysis of conjugated bilirubin or phospholipid by bacteria in patients with biliary tract infection or stricture, brown stones or primary bile duct stones, rare in the Western world and common in Asia. Risk factors: age, peaks in patients 60 to 80 years of age. Female gender, pregnancy, multiparity, obesity, and metabolic syndrome. Caucasian, Hispanic, or Native American descent. High-fat diet rich in cholesterol. Cholestasis or impaired gallbladder motility in association with prolonged fasting. Long-term total parenteral nutrition, TPN, following vagotomy, long-term somatostatin therapy, and rapid weight loss. Hereditary, P.D19H variant for the hepatic canalicular cholesterol transporter ABCG5/ABG8, short gut syndrome, terminal ileal resection, IBD. Hemolytic disorders, hereditary spherocytosis, sickle cell anemia, etc., cirrhosis, black/pigment stones, medications, birth control pills, estrogen replacement therapy at high doses, and long-term corticosteroid or cytostatic therapy. Viral hepatitis, biliary tract infection, and stricture, promotes intraductal formation of pigment stones. General prevention: uricodiol, Actigol, taken during rapid weight loss, prevents gallstone formation. Regular exercise and dietary modification may reduce the incidence of gallstone formation. Lipid-lowering drugs, statins, may prevent cholesterol stone formation by reducing bile cholesterol saturation. Commonly associated conditions: 90% of people with gallbladder carcinoma have gallstones and chronic cholecystitis. Diagnosis: history mostly asymptomatic, 80% 2% become symptomatic each year. Over their lifetime, 50% of patients with gallstones develop symptoms. Episodic right upper quadrant or epigastric pain lasting greater than 15 minutes and sometimes radiating to the back. Biliary colic due to transient cystic duct obstruction. Pain is usually postprandial. Pain sometimes awakens patients from sleep. Most patients develop recurrent symptoms after a first episode of biliary colic. Other symptoms include nausea, vomiting, indigestion or bloating sensation, and fatty food intolerance. Physical exam: physical exam is usually normal in patients with cholelithiasis in the absence of an acute attack. Epigastric and/ or right upper quadrant tenderness, Murphy sign, is a traditional physical finding associated with acute cholecystitis. Murphy sign has limited sensitivity and specificity. Charcot triad, fever, jaundice, right upper quadrant pain historically associated with cholangitis. Reynolds pentad, fever, jaundice, right upper quadrant pain, hemodynamic instability, mental status changes, also classically associated with ascending cholangitis flank and periumbilical ecchymosis, Cullen sign and Gray-Turner sign, in patients with acute hemorrhagic pancreatitis Courvoisier sign, palpable mass in the right upper quadrant in patient with obstructive jaundice most commonly due to malignant tumors within the biliary tree or pancreas differential diagnosis peptic ulcer diseases and gastritis. Hepatitis, pancreatitis, cholangitis, gallbladder cancer, gallbladder polyps, acalculous, cholecystitis, biliary dyskinesia, cholelithiasis. Diagnostic tests and interpretation. Ultrasound is the preferred diagnostic modality for cholelithiasis. Initial tests, lab, imaging, leukocytosis and elevated C-reactive protein level are associated with acute calculous cholecystitis. Ultrasound, US, is the preferred imaging modality. US detects gallstones in 97–98% of patients. Thickening of the gallbladder wall, greater than or equal to 5 mm, pericholecystic fluid, and direct tenderness when the probe is pushed against the gallbladder, sonographic Murphy sign, are associated with acute cholecystitis. CT scan has no advantage over US except for detecting distal common bile duct, CBD, stones. Mr. Cholangiopancreatography, MRCP, is reserved for cases of suspected CBD stones. However, MRCP has no therapeutic value, and preoperative MRCP is not more cost-effective than initial cholecystectomy with cholangiography in the diagnosis of patients with suspected CBD stones and patients with mild to moderate gallstone pancreatitis, GP. Endoscopic US is as sensitive as endoscopic retrograde cholangiopancreatography, ERCP, for detection of CBD stones in patients with GP. Hepatobiliary iminidiacetic acid, HIDA, scan is useful in diagnosing acute cholecystitis secondary to cystic duct obstruction. It is also useful in differentiating acalculous cholecystitis from other causes of abdominal pain. False positive tests can result from a fasting state, insufficient resistance of the sphincter of Oddi, and gallbladder agenesis. Cholecystokinin, CCK, HIDA is specifically used to diagnose gallbladder dysmotility, biliary dyskinesia. 10–30% of gallstones are radiopaque calcium or pigment-containing gallstones, visible on plain X-ray. A porcelain gallbladder is a calcified gallbladder, also visible by X-ray, that is associated with chronic cholecystitis and gallbladder cancer. Test interpretation. Pure cholesterol stones are white or slightly yellow. Pigment stones may be black or brown. Black stones contain polymerized calcium bilirubinate, most often secondary to cirrhosis or hemolysis. These almost always form within the gallbladder. Brown stones are associated with biliary tract infection, caused by bile stasis, and as such may form either in the bile ducts or gallbladder. Treatment. General measures treat symptomatic cholelithiasis. Conservative therapy is preferred during pregnancy, surgery in the second trimester if necessary, prophylactic cholecystectomy for patients with calcified, porcelain, gallbladder, risk for gallbladder cancer, patients with large stones, greater than or equal to 3 cm, patients with sickle cell disease, patients planning an organ transplant, and patients with recurrent pancreatitis due to microlithiasis in morbidly obese patients. Cholecystectomy may be performed in combination with bariatric procedures to reduce subsequent stone-related comorbidities. Prophylactic cholecystectomy is recommended for gallstones discovered incidentally during open abdominal surgery. Geriatric considerations. Gallstones are more common in the elderly. Age alone should not alter the therapeutic plan. Medication. First-line analgesics for pain relief. Nonsteroidal anti-inflammatory drugs, NSAIDs, are the first-choice treatment for pain control, which is equivalent to opioid therapy. Opioids are an option for patients who cannot tolerate or fail to respond to NSAIDs. Antibiotics for patients with acute cholecystitis. Prophylactic antibiotics in low-risk patients do not prevent infections during laparoscopic cholecystectomy, LC. 1a. Issues for referral. Patients with retained or recurrent bile duct stones following cholecystectomy should be referred for ERCP. Surgery/other procedures. Surgery should be considered for patients who have symptomatic cholelithiasis or gallstone-related complications, e.g., cholecystitis, or in asymptomatic patients with immune suppression, calcified gallbladder, or family history of gallbladder cancer. Open and LC have similar mortality and complication rates. LC offers less pain and quicker recovery and is the current gold standard treatment. In well-selected patients, single incision LC, SILC, and robotic LC are treatments for symptomatic cholelithiasis. SILC has not been shown to be superior to conventional multiport LC in terms of pain and risk of complication. Natural orifice transluminal endoscopic surgery, notes, is investigational. Surgery-related complications include CBD injury, 0.2%, right hepatic duct/artery injury, retained stones, duct leak, biloma formation, and bile duct stricture. Bile spillage during LC has been shown to be a risk factor for surgical site infection. Conversion to open procedure is based on clinical judgment. Male gender, previous upper abdominal surgery, thickened gallbladder wall, and acute cholecystitis increase the likelihood of need to convert to an open procedure. In 10–15% of patients with symptomatic cholelithiasis, CBD stones are detected by intraoperative cholangiogram, IOC. CBD stone, S, can be removed by laparoscopic CBD exploration or postoperative ERCP. IOC helps delineate bile duct anatomy when dissection is difficult. Routine use of IOC is controversial and may be associated with decreased incidence and severity of bile duct injury. Early LC, 24 hours after diagnosis of biliary colic, decreases hospital stay and operating time. 2a. For patients with acute cholecystitis, early LC, 7 days of clinical presentation, is safe and may shorten the total hospital stay versus delayed LC, greater than 6 weeks after index admission with acute cholecystitis. 3. A laparoscopic partial/subtotal cholecystectomy is a viable option in difficult operative condition, such as severe cholecystitis. Percutaneous cholecystostomy, PC, is used for high-risk patients with cholecystitis or gallbladder empyema. Interval cholecystectomy is recommended. Symptomatic patients who are not candidates for surgery or those who have small gallstones, 5 mm or smaller, in a functioning gallbladder with a patent cystic duct are candidates for oral dissolution therapy, ursodeoxycholic actigol. The recurrence rate is 50% once medication is discontinued. Extracorporeal shock wave lithotripsy is a non-invasive therapeutic alternative for symptomatic patients who are not candidates for surgery. It helps break down large bile duct stones before ERCP. Complications include biliary pancreatitis, hepatic hematoma, incomplete ductal stone clearance, and recurrence. Admission, inpatient, and nursing considerations for patients with symptomatic cholelithiasis, LC is typically an outpatient procedure. For patients with complications, i.e., cholecystitis, cholangitis, pancreatitis, inpatient care is necessary. Acute phase, NPO, for fluids and antibiotics, adequate pain control with narcotics and/or NSAIDs, ongoing care, follow-up recommendations, patient monitoring, follow for signs of symptomatic cholelithiasis. Follow patients on oral dissolution agents with serial liver enzymes, serum cholesterol, and imaging. Diet: a low-fat diet may help. Patient education: change in lifestyle, e.g., regular exercise and dietary modification, low-fat diet and reduction of total caloric intake, reduce gallstone-related hospitalizations. Patients with asymptomatic gallstones should be educated about the typical symptoms of biliary colic and gallstone-related complications. Prognosis: 50% of patients with gallstones become symptomatic. Cholecystectomy-related mortality is 0.5% in elective cases and 3–5% in emergency cases. Morbidity is 10% in elective cases and 30–40% in emergency cases. 10–15% of patients have associated cholecystectomy. After cholecystectomy, stones may recur within the biliary tree in patients with associated risk factors. Complications: acute cholecystitis, 90-95% secondary to gallstones, GP, ERCP plus or minus. Sphincterotomy of no clear benefit in patients with mild GP but reduces complications in those with severe GP. 4. ACBD stones with obstructive jaundice and acute cholangitis. In patients undergoing ERCP for CBD stones, early LC reduces the risk of recurrent biliary events. 5. B. Biliary enteric fistula and gallstone ileus-Bovarit syndrome is a variant of gallstone ileus where the gallstone lodges in the duodenum or pylorus, causing a gastric outlet obstruction. Gallbladder cancer Meretzi syndrome, extrinsic bile duct obstruction caused by gallstones lodged in gallbladder or cystic duct. References 1.